It just
Hello, hello, hello. Swagatam. On behalf of Maharashtra University of Health Sciences, Nashik, I welcome Honorable Vice Chancellor, Lieutenant General Madhuri Kanitkar, Madam, Dean of MPGI, Dr. Shishir Kumar Jha, Sir, Dean of Academics, Dr. Munal Patil, Madam, all the dignitaries, teachers, students, university officers for the Dr. Daulatrao Aher Memorial Lecture Series on subject Basic Building Blocks of Medical Research Methodology. I welcome today's guest lecturer, Air Vice Marshal Dr. Rajveer Bhalwar, sir. He is expert in subject of preventive medicine and community medicine, and having experience of over 45 years, including 37 years in the Indian Armed Forces. He is principal and dean of Pravra Rural Medical College, Loni. Before that, he was professor and head community medicine, FMC Pune, medical director, the Apollo Hospital, Hyderabad, principal and dean, IQ City Medical College, Durgapur, CEO of Command Hospital, Bangalore. He is also the expert member of UPSC, Government of India, advisor in public health, National Disaster Management Authority, Government of India, MCI accessor and member of MCI Curriculum Committee. Dr. Rajveer's core interest is in research. Total of 75 published papers, 61 out of these listed in PubMed. He also received Best Medical Teacher Award from Maharashtra University of Health Sciences in year 2008. Awarded commendations on 4 occasions by Government of India for exemplary services. Almost 12 times Best Research Work Award from professional bodies and Government of India. Today, Dr. Rajveer Bhalwar sir delivered his lecture on basic building blocks of medical research methodology. Kindly welcome Dr. Rajveer sir.
Honorable Vice Chancellor, General Madhuri Kanitkar, Madam, respected Dean of the Postgraduate Institute, So I start again. Thank you. Honorable Vice Chancellor, General Madhuri Kanitkar Madam, respected Dean of the Postgraduate Institute, learned faculty, and very lovely and fresh looking postgraduate students, ladies and gentlemen. At the outset, I must thank the Honorable Vice Chancellor and the Dean for giving me an opportunity to be here with you and share some views on a subject which has been close to my heart, and that is the basics of medical research methodology. To start with, when we ask the question as to why a discussion of research methodology, the reason is that research, as you all know, is essential for our own personal development. It's a baseline. We all need at least 2 papers to become associate professor and 1 more to become professor. That's a part. But then it's very important for advancement of our own professional knowledge and contribution to the care of the patients and the care of the clientele, because the developments in medical sciences which happen over the past 50 years, which have happened when we were undergraduates, and what we see now, the changes that have occurred are primarily because of the great contribution that astute clinicians have given in the field of research and which has translated into clinical practice. Also, history of medicine is replete with those examples where results based on very unscientific research was applied on patients only to do more harm. Over a century back, there have been examples of gastric freezing for peptic ulcers, application of leeches and bloodletting for congestive heart failure, application of tapesetone for treatment of migraine, all based on unscientific research methods, applied for many years till a lot of harm had been done, and finally they had to be withdrawn. And therefore, it's important for all doctors, all clinicians particularly, to have a working knowledge of the basics of research and what we call as the basic building blocks of medical research methodology, which I should be talking about. I propose to discuss a total of 13 essential basic building blocks of medical research methodology. Truly speaking, each of these building blocks is a subject by itself by now, and people have written textbooks on each of these building blocks. I propose to cover them superficially, just to inoculate the audience, which I believe consists of mainly postgraduate students and who are the budding scientists for tomorrow. And I'll spend about 5 minutes on each of these building blocks. So let us start. What is the first building block of medical research methodology? Is the realization that we have to appropriately and correctly and painstakingly develop the research question, the most important. The second one is we have to understand that research means variables. It's all a study of the relationship between variables and the scales of measurements that we have to appreciate. The third building block is whether we study only 1 subject or 2 subjects and come out with the findings, apply it to the fraternity, or else we need to study many patients or many subjects. The fourth one is the basic concepts that underlie the concept of populations and samples, very essential when we do research. Next one is the concept of generalizability of the findings, or what we also call it the loss of external validity. Next one is the basic concept of random error. We also call it by chance or sampling error, and very happily we call it as the p-value. And when we get a p-value of significant less than 0.05, we are very happy. But we must understand what it actually means. Next one is whether we study only 1 group or we study 2 or 3 or more groups. Next one is the basics involved in hypothesis testing and quantifying the relationship between exposure and the outcome. And the last 6 months are number 9 is the block of selecting the correct research design. There are a number of designs, but we have to select out the best which is suited to our research question. Next one is I'll deliberate on ensuring the correctness of measurements, followed by the concept of bias, which we also call as the systematic error or misclassification or loss of internal validity in a study, followed by the concept of confounding and how do we control confounding. And lastly, how do we ensure a proper statistical analysis? The first one, and very important one, is to develop a proper research question. Believe me, there was a review by one Dr. Robert Fletcher. He is a rheumatologist, but he is into clinical epidemiology. They reviewed randomly almost 100 articles from the leading journals, and they sent questionnaire to the authors, and they said that in almost 50% of those published articles in good journals, almost 50% of the authors were not sure what they wanted to do. They were not clear about the research question. It is also a fact that in case you develop your research question properly, then half of your research is over, successfully over. And a proper, as I said, half of the research depends actually. And also the fact remains that in high-level medical research, many of you after your dissertations in MD and MS will go for high-level research, will go for PhD, will go for big projects, which Honorable Vice Chancellor is already working on many projects. The fact remains that developing research question in those high-level projects or at PhD level may take almost 6 months to 12 months. Usually it takes that much time to only develop a proper research question. And once you have developed a proper research question, half of the job is done. Developing a proper research question is a very painstaking job, and it's a very professional job process. It consists of a series of steps which one needs to follow, and the starting point is generation of ideas. These ideas come to us by our own professional experiences. We must have seen some patients by now. We must have seen some interesting cases. We are generally interested in some aspects. So that is from where it starts. And also thorough reading. A good researcher has to be, these building blocks are separate. These are some technical issues. But the fact remains that a good medical researcher has to be a good professional, has to be a well-read person, and should be fond of reading. If the person is not fond of reading, is not a good clinician, then probably research is not the game he should be playing. So after a good, you identify your own area of interest, which comes by your experiences, also a lot of discussion with your professors, your teachers, the peers, and so on. And then after that, you identify an area, broad area of interest. A broad area of interest could be infectious diseases, could be malnutrition among children, could be dialysis is good or a renal transplant. Those are all broad areas. After that, once you have identified a broad area of interest, the next step sequentially is that you read around the subject. Now, around is a wide reading, very wide reading. You go through the concerned journals, go through the summaries and the abstracts of that. Those you find pertinent, interesting, note it down, and keep on moving fast. After reading around the subject, you will be able to identify the area of specific interest, which is more specific into that field. Once you have identified that area of specific interest, then the next step is to read into the subject. Whereas reading around is an in-bit reading, reading into the subject is in-depth reading. You have identified a specific area. Now, go on to the textbooks, go on to the specific research works which have been done in that area and read them. See what the other workers have done, how they have measured the variables, what variables they have seen, what are the confounding variables they have measured, what are the various elements of bias they have, which we'll go through just now. And after going through in depth, keep on making your notes. And having done that, we would then identify a very specific item where we'll realize after so much of reading, both width reading and in-depth reading, that there is an area which interests us. And by my reading, I identify that some work has been done in this area. But at the same time, there are certain gaps still existing in the knowledge, which need to be filled up for the benefit of the patient care. And at this point, write a tentative guess that this is my tentative guess, which is going to be a hypothesis and which we will proceed in our research to prove or disprove. For example, just to give a wide example, suppose we identified prevention of COVID infection, a recent disease which afflicted us. We can write a tentative research question after a lot of reading into the subject, identifying the various and discussion with our seniors and peers. The question could be, will drinking 5 grams of turmeric powder, it was very common taking all these herbs during the COVID times. So the question could be, will drinking 5 grams of turmeric powder in warm water 2 times a day without any added herb or drug, only turmeric, reduce the chances of acquiring COVID infection? This is just a tentative guess. So this becomes my first step of my hypothesis. After this, next thing is, now we have got to make this tentative research question as specific as possible. As specific as possible, enlarge it. The same question, I have tried to make it more specific by saying, Can drinking 5 grams of turmeric powder without any herbs or pharmaceuticals in 250 milliliter of warm water 2 times a day before meals reduce the probability of acquiring COVID infection by a factor of 25% among adults aged 18 years and above living in the city of Mumbai after duly considering the confounding effect of age, gender, and existing comorbidities like diabetes, IHD, hypertension, malignancy, and so on. This is a more specific question which comes to you after a lot of reading and discussions. So what a specific research question is, at the end point, a research question should be as specific as possible. And how do we test that our research question has become pretty good specific? There are 5 parameters for that. A good specific research question, the moment anybody who is examining your protocol or you yourself read the research question, you will be able to answer these 5 questions. It should tell us what is the suspected exposure or cause that we are trying to study. For example, in this particular example that I gave you, drinking 5 grams of turmeric powder without any herbal drug 2 times a day is that exposure variable which I want to study. This is what I feel is going to make a difference in the outcome, that is COVID. The second thing a specific research question will tell us very clearly is what is the postulated effect or the outcome of this exposure which I'm trying to test. For example, preventing COVID infection in the question that I just narrated is a clear indication of our postulated effect or the outcome. The third aspect which a good research question tells us will be the magnitude of the effect. How much magnitude, how much would the effect would be? In this example, it was 25% reduction in the probability of acquiring infection if using the exposure variable. The fourth aspect, we should be very clear on reading the research question is, what are the possible confounding factors, which I'm going to study. For example, again, in this research question that I just gave the example, age, gender, existing comorbidities like diabetes, hypertension, and so on, were all the possible confounding factors. And lastly, a good specific research question will give us an idea of the general settings of the study, where, on whom, which place, what time. In this example, with all adults more than 18 years staying in Mumbai. Having written a specific research question, showing it to your peers, your guide, your seniors, and those experts who have worked in this field, the next thing is test it for these 5 things. We call it as funds. Some books put it as finer and so on. But the 5 things you must see, even after a very specific research question has been developed, is whether it is feasible for you. Do you have the professional caliber or time or money and so on to do this research question? Because if it is not feasible, then might not do this research question at all, or then try to get funds, try to get training if that is possible. The second aspect, which we must test our research question is whether it is ethical. I need not go into the more details. It's a subject by itself, but it should be cleared by the institutional ethical committee, and it should sound ethical. Actually, ethics comes from the heart, first of all, then it goes to the ethical committee. The third thing is it is relevant for you. Using condoms or oral pills is a very important question, but if a neurosurgeon starts doing it, it may not be relevant for neurosurgery. So see whether the question which you are doing, it may be very specific, very good, but it should be relevant to your specialty or the settings in which you practice medicine. The fourth thing is it should have some novelty. Something should come out. Always be ready to answer. When you make your research question, be ready to answer that question. If so, so what? That people ask, आपने इतना बड़ा पर्चा लिख दिया, रिसर्च कर दी, बड़ी प्रोजेक्ट कर दी, इससे फायदा क्या है? That is a question anybody will ask you. So it should have some novelty. If you do a research work and come out again with the finding that smoking a pack of cigarettes every day for 30 years is a risk factor for lung cancer, you have not added anything to the field of medicine. The last thing is specific. As I have given you the example, it should give those 5 answers: exposure, outcome, confounders, and so on. Now we move on to the second building block. Having made a good research question, spend time, spend professionally, because do appreciate what we go on through the next few building blocks. If you have developed your research question well, if you have developed it professionally after a lot of reading, discussion, then you will be very easily able to tackle the other building blocks that we go through now. The second one is, based on the research question, define clearly the variables and the scales of measurements for these variables. At the very start of your study, when you're writing your protocol, you should very clearly mention, these are my variables of study, and this is how I'm going to measure. Now, what is a variable? Actually, variable, what we study in research, everything is a variable only. We don't study anything else. By definition, a variable is any quantity or quality of a subject which we are studying, which can be measured and which varies. For example, gender is a variable because you can measure it, male or female, and it is likely to vary. If I am a male, the probability is that the next subject, maybe the 50% probability is that the next subject would be a female. It's a matter of chance that the next 10% may be male, but it should, the element, the probability of variability should be there. That is what a variable is. And it is important that we specify at the end of the research question, which all variables will be studied in our study and the measurement scale of each and every one for them, because the subsequent statistical data, what we start running at the end of the research, statistical data, actually that should be planned at the time the research question is being made. And the most important thing is the variables you are going to study and on what scale you are going to measure them. I'll just come to that. Now, what variables are basically, if you put it simply, are the headings. Blood pressure, you are going to measure, let's say, eating turmeric powder or not, developed COVID or not, gender, diabetes present or not. These are all variables actually. These must be listed. Based on the research question, list out each and every variable. For example, the example that I gave you, all these age, gender, socioeconomic status, everything was a variable, which we had to study in our research work. Ultimately, if you see, at the end point, every research work is nothing but a study of the association between variables. When you try out a new typhoid vaccine, whether it's capable of preventing enteric fever or not, actually you are studying the association of two variables only. One variable is typhoid vaccine given or not given. It's a variable. And the second variable is that enteric fever happened or did not happen. That is also variable. So ultimately, you're not doing anything. At the end point, at the final point of your analysis, you are only showing the association between two variables, and that is what all research is about. For example, the example that I gave about turmeric, we would ultimately be interested in what? We would be interested in assessing whether one variable, that is drinking turmeric powder or not drinking turmeric powder, is related to other variable, which is getting COVID infection or not getting COVID infection. So identify all the variables and their scales of measurement. Now we'll not go into the scales of measurements in detail. It's a huge topic, but very broadly, what you have got to decide is how you measure a variable, because as we said, by definition, variable is something which is measurable. It can be a quantitative variable, it can be qualitative variable. Without again going into details, a quantitative variable is one which is recorded in quantities. Aapke pro forma mein, when you write down what after measuring, if that is a number which is coming there, then it's a quantitative variable. It's simple. And if it's some word or verb or quality or noun which is coming, then it is a qualitative variable. For example, if against gender you're writing male, then gender is a qualitative variable. It's testing the quality of a subject. If you're writing blood pressure, opposite it, you're writing 140, or you're writing total serum cholesterol 250, it's a number. Grade of Aher score 8, it's a number. Therefore, it's a quantitative variable. That is how you differentiate in very simple terms. And each of them has got three further characteristics. A quantitative variable can be discrete. Discrete variable, it can take only integer value, number of children, 1, 2, 3, whatever, but nobody would say I've got 1.2 now children. Okay. So a discrete quantitative variable is a number which has only integer value. There is no decimal allowed in that, not possible. The second one is a quantitative continuous, which is number, but it can take anything. At least theoretically, it can take any value between two integers. For example, when you say blood pressure, you'll say it's a discrete variable. Because normally we measure it 128, 130, or if you have a better blood pressure instrument, you may write 127 also. But truly speaking, if you have the desire to measure blood pressure and you have got good ears, I don't have, and you have got a good instrument, you can measure blood pressure as 127.325982 also. Anything between 127 and 128. So it's theoretical, but this is what a continuous variable is. So blood pressure, serum cholesterol, most of the biochemical parameters, they are all continuous variables. And the third quantitative variable is the ordinal variable. An ordinal variable is number, but not a true number. So it's like quantities. Grade of satisfaction 3. Apgar score 6. Fine. Now, Apgar score of 2 and Apgar score of 4. Two babies put together don't make a Apgar score of 6. So they are not true mathematical quantities, but they are numbers. They indicate some sort of grade. And therefore, these are known as ordinal. Why it is important is that the statistical procedure, if you are using a discrete variable or a continuous, is different. It will be t-test and so on. When you are using ordinal variable, it goes on to non-parametric tests like Pascal values and so on. So the differentiation, you have to decide. Nobody else will decide. A statistician will be happy doing the test for you. There are computer packages also. But suppose if you have, at the very outset, decided to measure blood pressure as hypertensive or normotensive, then your entire data sheet will be hypertensive, normotensive. And then you want to get back and find out what was the actual blood pressure and now I want to do a t-test on this and all. It is not possible because it has never been recorded that way. So decide at the point of developing question what the scale of measurement is going to be. And similarly, as far as qualitative is concerned, again, they can be of three types. The commonest is qualitative, is dichotomous, most commonly used, and we'll deliberate on it little later or little more. The dichotomy is yes or no, this or that, treatment given, not given, new drug given, or standard treatment given, alive or died, recovered, not recovered, COVID developed or not developed. All these are dichotomies, this or that. Only two options are possible. Okay. The second one is qualitative, but a polychotomous nominal. A polychotomous nominal is more than two categories. Dichotomous has only two categories. The polychotomous has got more than two categories. And these categories do not have any sensible ordered relationship. Blood group A, B, O, A, B. You can put it as A, B, O, A, B. You can put it as A, B, O, B, and A, whatever way you want. Religion. You can put it as Hindu, Muslim, Sikh, Christian. You can put it as Christian, Sikh, Muslim, Hindu, whatever way you want. There is no sensible ordering of relationships. Those are the polychotomous and nominal variables. But there is a third one, which is a polychotomous ordinal variable. And there is a sensible ordering of relationship. For example, satisfaction with the hospital services. Satisfied, very well satisfied, highly satisfied. There is a definite ordering of relationships. That is a polychotomous ordinal. It's a qualitative variable. Why I'm deliberating on it is you have to decide. And it depends again on the purpose of your research question ultimately. And that is, it becomes very important to develop a good research question, because whichever variable you measure, the statistical test will become very different. For a dichotomous variable, it becomes a 2x2 chi-square test and a odds ratio or a relative risk and so on. For a polychotomous, it becomes a simple nominal chi-square. But for a polychotomous ordinal, it becomes a linear trend analysis. So at that point of time, just remember this much and decide at the point of making the research question, what all variables and what scale you are going to measure them. And ultimately, do remember this mainly for the, I'm sure the learned faculty may not be needing it, but the postgraduate, since they are still just starting. Always remember, write down at the point of a research question, variables are of three types. Exposure variable. You do a clinical trial, giving the drug, new drug, or not giving the new drug is a exposure variable. You are going to expose the subject to that variable. Okay. The second one, there will be outcome variable. You are giving a new drug, the outcome will be cured or not cured, right? And there will be confounding variables. We'll cover it up. Write down these are in a clinical trial. You can have a primary exposure variable. You can have a secondary exposure variable also. You can have one drug and another drug also being given. Similarly, in a clinical trial, you can have a primary outcome. You can have secondary outcomes also. So those are different things, but do make out these categories and classify your variables into these categories. And for each variable, write down how I am going to measure, which scale I am going to measure, qualitative or quantitative, and so on. So with this, we move on to third building block, one subject of many. And for this, just have a look at this example. It's an old example, published in a very reputed journal. I'll quickly read it out. 58-year-old woman with moderately severe Parkinson's disease recounted to her family physician that 3 months ago, while taking amantadine hydrochloride 100 milligram twice daily to prevent flu, in 1969, it was used as an antiviral drug. She experienced a remarkable remission in her symptoms of rigidity, tremors, and akinesia. These symptoms promptly returned after 6 weeks of stopping the drug. The findings, the result was very clear. The effect on the patient was striking. The medical world was in desperate need of effective for Parkinsonian at that point of time in 1969. However, this report, single report based on one single case, could not lead to immediate change in the clinical practice. It took clinicians tried out amantadine in a limited number of patients initially, thereafter in a standard clinical trial. And from the initial description of 1969, it took a couple of years before amantadine could be introduced as a regular anti-Parkinsonian drug. So, what do we get out of this? What we get is that though clinical practice and research utilize exactly similar procedure, and that's what I said. Being a good researcher, a doctor had to be a good doctor also. That's basic. You have to be a very good professional in your own specialty. And in both of them, whether it's a clinical practice or it's research, you utilize the same methods. It's the same measurement blood pressure, it's the same echocardiography, it's the same MRI. There's no difference. But the only difference, which is very major, is that the clinical practice is my patient here, one person, whereas research is many. In research, 1% does not make a difference, but in clinical practice, it makes all the difference for us. Now, if we agreed that the results on one patient or two patients does not make a difference, so we have to study many, then how many and which all? And with that, we move on to a very, very important building block of population and samples, a very important concept in research. See, what happens is, whenever we do a research, we always have a large population in mind. Suppose you are trying turmeric powder. So you have got some millions of people in Mumbai or Maharashtra or India who will be drinking turmeric and getting free of COVID. There are millions of people on which the result of a research will be applied. That is what we call as the total population in research parlance, or the reference population, or the very commonly called as universe. It's very difficult to define it. It's huge population on which ultimately my research results are going to be applied. But what actually happens is that in that process, what happens is that this is the large reference population of all the people, adults in the country who are likely to suffer from COVID and likely to take turmeric powder. These are 140 crores here. But truly speaking, I don't study all of them. I don't have to. What I study is only a sample taken out of this large reference population. So I take out this sample here, and after studying this sample of say 1,000 subjects, what I do is, after I'm convinced from my 1,000 people that drinking turmeric powder helps in preventing COVID, then I would say that all Indians start drinking turmeric powder. So what I do is I take out a sample, do the study on a sample, and then apply my results back to the total population. This is the issue which happens in research, and it has to happen. The results are taken from a sample, drawn from the reference population, and extrapolated back to the total population. And here the issues start. So what are the issues? Whenever we study a sample, which we always will be doing in research, firstly, there could be error of external validity or lack of generalizability, that we have done a study, but it so happens that we'll not be able to apply these results onto the total population on which we want to apply. The second thing is a very unique concept of sampling error or random variations, or what we call chance and p-value, all are the same, that the results obtained from a sample are likely to be different from the actual value. Suppose I do a study on what is the average level of hemoglobin in pregnant women who come to my intimacy clinic. I take a sample of only. There are millions of pregnant ladies all over India. I'll apply that to India. Suppose I get a result of 11 grams per deciliter. But it is not necessary that all over India that will be the average value. It will be 12, it will be 10, it will be very different. And this happens not because I have done the study wrongly, Not because I have taken a wrong sample, but because there is a random variation. It happens, it has to be because nature has created that error. And therefore, my results are likely to be different just because of matter of random error or chance. And if I take another sample of 1000, I may get 10 grams of hemoglobin. If I take a third sample of 1000, I may get 13 grams. So every sample taken is unique is different. That is what is known as sample to sample variations or sampling variations. These are the two variations which are important in the concept of population samples. We tackle the first one, which is lack of external validity. For example, I wanted to do a study. What is the seroprevalence of HIV infection among the healthy young adults in our district? Simple research question. So what is my reference population? Reference population or universe is the large collection of people on whom my results will apply, which in fact means that would be healthy blood donors in our district, which may be a total of 1 to 2 million people living over an area of 200 square kilometers of Nasik district. That is my reference population. But what do I study? I can't study all those 1 million people, healthy people all over, going all over in 200 square kilometers. It's not possible. It's not required also because we have a process of sampling. So we decided to study 1000 subjects. It's a reasonably good number. We'll test 1000 subjects for their seropositivity. Fine. So what we did was, there is a STI clinic, sexually transmitted infectious clinic. They are there under the national program. So we went there. There are males coming there. We tested all of them. We tested 1000 of them and we found 100 of them are positive. So we said the results are, we put the results back to the total population said in our district among healthy young adults, the HIV seropositivity is 10%. Doesn't sound logical. Doesn't sound logical because what happened was that this sample was not representative. These STI patients, they do not represent our reference population, which was all healthy males. And realizing our mistake, and what we did was we made a complete list of all the males in the entire district. And by random numbers, we selected 1000 adult males from the blood bank, healthy blood donors, voluntary blood donors. And we found 10 of them are positive. And now we've got the correct rate, which was 1%. So what happens is, the way I did my study was not wrong. I did the testing properly, but if my results can be applied to another population. If you ask me what is the seropositivity for HIV among STI patients, is 10%. I can say that. But my reference population was all healthy young adult males. I can't apply this result onto them. And that is what is known as lack of external validity or lack of generalizability. Externally, my study is not valid. Internally, it may be valid. So the lesson learned is that the sample should be truly representative of the population. And otherwise, the findings cannot be generalized or extrapolated to the reference population. This is known as loss of external validity or loss of generalizability. And what do we do? What do we do is that we draw the sample in a way that every member in the reference population has an equal chance of being selected. This is what we call as probability sampling or random sampling. Suppose we are 100 of us here, and I want to select out 10% for a study. Then 10% are selected out of 100. There are 100 people. Each one of us should have equal probability that I also have 1% chance. VC madam also has 1% chance. The lady positive sitting there also has 1%. Probability sampling all about, and that is the factor which has to be ensured when we want that our studies should be externally valid. That's next is this, the so-called p-value. That's also again a concept involved in population and samples. Now, basic concept in these are all the same thing: random error, chance, sampling error, sampling to sample error, sampling variation. These are all the same thing in statistics and research methodology. And the basic thing is, as long as you are studying a sample taken from a population, it may be the most representative sample, very well random probability sample, and you are making the best measurements, ideal measurements even then. Because of the natural law of random error, your results are likely to be different from the reality which exists in the population and which we are trying to estimate. I'll give you an example. Hypothetical. Suppose we wanted to find out what is the seropositivity for COVID in young adults in our district. So the reference population we define as 1 million young adults, which are spread again over entire 200 square kilometers of Nasik district. Now, just for the sake of discussion, let us assume that the true seropositivity is 50%. I mean, it's only for the sake of discussion. Had we known it is 50%, we wouldn't have done this study anyway. But let us start a discussion. So, now see this situation. Suppose we thought we'll do a study only on one subject. So first subject we'll take randomly and we selected the subject. Naturally, either the subject can be positive or negative. We found this one to be positive, negative. So the actual reality was 50%, but this result was 0%. So we deviated 50% from the truth. Am I correct? Okay. Now we said no, 1 is a very small number. Let us say 10. So we did a study on 10 subjects. This time we found 9 are positive. So our result was 90% positivity. This time we have deviated how much? 40% from the truth. Fine. So we kept on increasing the sample. Finally, we tested 1 lakh people for COVID positivity. And this time we found that for 47,800, that is 47.8% are positive. Reality was 50%, which we had assumed. This time we have deviated 2.2%. No, but we said, no, हमें तो actual reality देखनी है. Then what we have to do is then go out and test all the 10 lakh young people in the entire Nasik district. Then you will get definitely 50%. Whatever the reality, if it is 30%, we will get 30% only. But till the time, but what is the take-home message from this table is like this. As long as we are studying a sample, the results from our sample are always likely to be different from the truth that exists in the population, in the total population, and which you are trying to estimate. Now, what you appreciated was, in the previous slide, as we increase the sample size from 1 to 10 to 100 to 1000 and 1 lakh, we moved closer and closer to the truth. We were 50% off the mark, then 40%, 19%. And finally, when we studied a very large sample, we were just 2% off the mark. But we are still off the mark. There was some error. And if you wanted no error, then study the whole population. So this is the natural phenomena of chance or random error or sampling error or sample to sample variation, which we call as the p-value. There's nothing very great about it. It has to happen. But then what do we do about it? What we have to do about this phenomena is, number one, be aware of the phenomena of chance. Where it is there, we have to accept it. Number two, always try your best to use a probability or a random sample which is representative. Number three, use an adequately large sample. And that is done by calculation of adequate sample size, which has got its own statistical inputs and parameters. I'm not going to dwell upon it. But at the start of study, the moment you finalize your research question, you must go to the statistician or to the computer package and give those inputs, which the statistician or the computer package will ask you. It will ask for you something very, very funny things. It will ask you, what is the beta error you want? What is alpha error you want? So you must be prepared. At that point of time, you must be prepared to tell, okay, I want alpha error of 5%, a beta error of 20%, whatever. Calculate an adequate sample size. And after you have done your study with the adequately large sample size, then lastly, calculate by statistical procedures how much you have deviated from the reality. That is the p-value, whether it is less than 0.05 or it's more than 0.05. And there's nothing very great about 0.05. A p-value of less than 0.05 only means that I have estimated something and the probability that my result may be different from the reality which I'm trying to estimate in the large total population is only less than 5 in 100 chances. That is all. A p-value of more than 0.05, suppose it was exactly 0.06, it would have meant that the amount of probability that I may have gone wrong in estimating the reality is 6 in 100 chances. It doesn't, 5 and 6 don't really make a difference. So therefore, rather than focusing on p-value, you must focus on an adequately large sample size to start with, and a drawing of a probability sample. That is more important. And of course, at the end of the study, calculate the statistical aspects. We move on to number 7, whether study one group or two groups. There's another example, published in a very reputed journal. It ran like this: some strokes are caused by cerebral infarction in the area of brain distal to an obstructive segment of the internal carotid artery. So It was thought that we can prevent stroke by bypassing the disease segment. So that what we can do is we can connect the superficial temporal artery to the internal carotid distal to the obstruction, beyond the obstruction. And the procedure was applied on a series of patients, and these patients showed marked improvement in many of them. So with this background, the improvement in many of the patients, and also the documented success of another analogous procedure, that is the CAVG, which was well known by the time, this procedure became widely used in 1970s and 1980s. However, one thing which has to be kept in mind at this point of time is that no control group was studied at that time. Only a series of patients were studied. So in 1985, people thought, let us conduct a randomized control trial. Well, that's very hype thing. So a RCT was conducted in which the patient with cerebral ischemia and a obstructed internal carotid were randomly allocated this time to surgical or medical treatment. In the surgical group, the operation was a technical success. Technically, it was very good. 96% of the anastomosis were patent a year after surgery. Surgery was very good. However, what happened was surgery did not help the patient per se. Mortality and stroke rates after 6 years, they are in fact slightly higher in the surgically treated patients compared to the medically treated patients. Moreover, deaths has occurred earlier in the surgically treated patients. There is where the difference comes. We can do our study on a single group, which is known primarily as the descriptive studies. You all must have gone through epidemiology, undergraduate epidemiology. A descriptive study is done only on one group of subjects. It does not test a hypothesis. It only describes a phenomena. What is the seroprevalence of HIV in the young healthy blood donors? So 1% is my result, fine. You have not tested any hypothesis. But at the end of it, you may come out with hypothesis. Your descriptive study may say that out of the children who suffer from acute studies, a single group studies, a conclusion is drawn, a hypothesis is generated, but the hypothesis is not proved there. On the other hand, when two groups are studied, it's known as comparative epidemiology. It compares two groups. A group which has got the exposure with a group which does not have the exposure, what we call control, or a group which has the outcome with a group which does not have the outcome. And therefore, any conclusion, if it is to be drawn regarding the risk of a disease or cause of a disease, or anything regarding therapy, treatment, surgical or medical, or prevention, a vaccine or a chemoprophylaxis, or anything to do with prognosis, the final conclusion, the final answer can be given only by comparison, which has to be made between at least two or more groups. And this is what you know as the analytical epidemiology. We move on to the next one. So the last block only said that if you just want to describe a phenomenon, not that they are not important, they are very important, particularly for MD/MS level dissertation, those are the studies generally they are done because it describes problem. What is the percentage of patients in my hepatitis ward who will die? Simple description, fine. But when you have got to prove a point, you have got to prove a point regarding the risk factor or the prevention, treatment, prognosis, then it has to be a comparative study, and they could be of various types, the randomized control trial, cohort study, and so on. Now, this is very important aspect, a very, very important building block of that is the quantifying of the exposure, that is the cause and the outcome relationship. I'll start with a hypothetical example. There used to be self-administered domiciliary treatment for tuberculosis earlier, and it was not showing the expected cure rates. So it was thought that whether some other form of modality of treatment could help out, and it was thought that in case a directly observed therapy could be tried, that could help us out. So a randomized control trial was done, and the outcome of cure was based on microbiological, clinical, and radiological criteria laid down, very clear criteria. 300 patients who were sputum positive were randomized, 150 were giving self-administered domiciliary treatment. They gave the medicine themselves, and the remaining 150 were given the same medicine by directly observed by some other health worker. These are the results. Now this, just have a look, gaze at this table for just a few seconds, because this will, and this is basically the heart of any medical research. This is the column, shows the exposed. Exposure means those who were given dots. Not exposed means who were not given dots, because our trial modality was dots. So self-administrator were not exposed. And this is the outcome achieved. Outcome was achieved means those who were cured, and outcome was not achieved, those who did not get cured. Exposure present, exposure absent, outcome achieved, outcome not achieved. Please have a look at this table. I'll repeat it again. But if I have to ask you a question, that was what the cure rate among the exposed people, that is who were on dots, will easily say it was 121 out of 150 or 80%. This is the incidence among the exposed technically from the research point of view. If I ask you what was the cure rate among those who were not exposed means who were doing self-administration, you will say 59 out of 150 or 40%. And this is what we call as the incidence in the non-exposed. And if I ask you, was dots effective? Automatically you will say, yes, it was effective. It was 2 times more effective. How do you say that? Is this? Why 2 times? Because 80% was the incidence of cure in those who were exposed, and 40% was the incidence in those who were not exposed. To divide 80 by 40, and it's simple, 2 times. Dots is 2 times better than self-administration. This is what we call in research methodology as relative risk. Very, very important term, or risk ratio, or a counterpart of odds ratio. Very common. Keep this with you. And this is simply obtained by dividing the incidence of the outcome in the exposed group by the incidence of the outcome in the non-exposed group. This is, people say, very good research methodologists say that if you are comfortable with this table, this is known as a 2 by 2 table. If you are comfortable with this, then actually you have become a very good research methodologist. What this table is, it is known as 2 by 2 because it has got 2 rows. A row which shows exposure present, a row which shows exposure is absent, and it has got 2 columns. A column which shows outcome was present or achieved, and another one which shows outcome was not achieved. Fine. And these 4 cells inside, which A, B, C, and D I have put, this is the heart of the 2 by 2 table. And table cell A apparently are those subjects of your research who had the exposure and also developed the outcome. B are those who got the exposure but did not achieve the outcome. C are those who were not exposed, did not have the exposure, but still achieved the outcome. And D are those who were neither exposed, did not get the exposure, and did not get the outcome. And just keep on looking at this table whenever you get a chance, and try your own situations, manufacture your own situations. This is my research question. So what is my exposed group? How do I define E plus? What is E minus? What is O plus? What is O minus? This technically A is E plus O plus. Exposure was present and outcome was also present. This is what the 2 by 2 table is. And in most of the modern researches, you will find this 2 by 2 table coming in, and all the statistical analysis of RR, odds ratio, confounding control, everything is based on this 2 by 2 table. And this is how you calculate. This is a 2 by 2 table. Primarily, you calculate the incidence in the exposed group, incidence of the outcome in the exposed group, and incidence of outcome in the non-exposed group, and calculate the overall risk. And this is 2 times is what the efficacy of the new modality is as compared to the standard modality. So we move on to the next one. If this is clear, select the correct design. Now design, don't start your research question by saying mujhe to clinical trial hi karni hai. Your design should be the one which appropriately answers your research question. Your research question is primary. There are a number of research designs. Most common are the basic designs, incomplete and hybrid. Leave them. At present, probably you will not be involved in them, but basic designs are of 2 types. It could be intervention. When actually intervention has been done into a group of subjects, the intervention could be a new drug, it could be a new surgical modality, it could be a new vaccine, a preventive modality, or whatever. But something has been given deliberately by you as the investigator, by you as the researcher. On the other hand, observational are those which compare people, which study people, but only observe. You are not. Smokers, are they susceptible to IHD? You have not told them to smoke. You have not told half of them you start smoking, you don't smoke. No, they are already smoking. Nature has created the intervention for you. You are observing, but still you are drawing some conclusions. These observational, as I said, could be descriptive. With only one group is studied. They don't start with a hypothesis, but they give you very good conclusions and help you generating hypothesis. On the other hand, they could be analytical, and these could be cohort studies, this simple undergraduate epidemiology. It could be cohort, it could be case control, or it could be cross-sectional analysis. These are the type of studies, and select out the one which correctly answers your research question. And in short, if your research question is a simple description of an outcome, you don't want to make any comparisons, you don't have any hypothesis to prove or disprove, then you have to do a descriptive study. Single group, I want to see what is the level of malnutrition among children in my attending my pediatrics OPD. It's a simple descriptive study. Come out at the end that 20% of the children are grossly underweight. Fine. But in case you are wanting to do the natural history of history, the following up, what happens to a series of patients who start with COVID until the end point, how many survive, how many die, how many go into complications and all, do a longitudinal descriptive study. It's again a descriptive study, but a longitudinal, you have to follow them up. But in case you are testing a risk factor or for a cause of a disease, then your design available to you is either a case control study or a cohort study. We will not go into details, but these are the two which are only available to you. If you are testing the efficacy of a drug, a new drug, or a preventive measure, a vaccine, and so on, then the only design available to you is the experiment or an intervention study, loosely known as randomized controlled trial. If you are studying a prognostic factor, whether flapping tremors hote hain, to mortality aage hogi ki nahi viral hepatitis mein, it's a prognostic factor being studied. You have to do a cohort study and compare two groups. A group of having viral hepatitis and having flapping tremors, and another group having viral hepatitis but not having flapping tremors. Follow them up for 1 month and see how many die. A prognostic factor study has to be a comparative study on a cohort lines. And finally, if you are assessing the performance of a diagnostic test, then it has to be a diagnostic test study, which is a very different type of study. If you want to see whether this particular new test that you have got, or somebody brought, some representative have got, whether how well it functions in the diagnostic accuracy against a gold standard, then it's a different type of study. So it depends on your research question. You select out the study, not that you select out a study and then do a research question. Okay. Next one. The basic measurements have to be absolutely correct. There is where many of us falter. A measurement should be correct. For example, you are measuring hemoglobin. The correct measurement is take a hemoglobinometer, make the measurement, and so on. But if you start that, give dikhao, aankhein dikhao, is the anemia hai, or iska hemoglobin 6 hoga, that doesn't help because that's not a correct process of measurement. A correct process of measurement has to be decided by you at that point of time when you're writing a research question. For every variable, you have to write down what is going to, and the correct measurement process should have two things. Number one, it should be valid. It should be accurate. That is, we should be measuring what we really intend to measure, not something else. For example, if we start measuring the presence of COVID infection, simply by asking whether a person has got symptoms of छींक आती है कि नहीं और COVID हो गया, वैसे नहीं होता. You have to define the process of measurement, whether RAT करेंगे या RT-PCR करेंगे. And second, it should be reliable. Repeated measurement should give consistent results. If inadvertently your N/10 HCl is diluted to N/20, you will get reliable results. Every time you will get the same results from the patient, but the hemoglobin will be 2 times. So both the elements should be there. It should be valid, that is accurate, it should be reliable. Now, what do we do for correct measurements when we start the research? Just these 4 things. Number one, follow the standard case definitions, which have been laid down by the eminent bodies. We start from the good old Jones criteria and till the NCCP criteria for metabolic syndrome, but use the standard criteria if they are there, laid down by standard bodies. Second, use the standard techniques of making the measurement, laid down in our books or by eminent professional bodies or by the experts. Use the correct instruments for the measurements and keep it standardized. The external quality control mechanism should be maintained. And finally, very important, when you do a large level research, you will not be doing the measurements. You will have workers working for you. So train all the workers in the correct process of measurements, test them and certify them and periodically keep on testing them. This is how you make the correct measurements. And the next one is, this is very important because this is very commonly people evaluated bias. Now, what does bias mean? Bias actually, if we see, is only a differential treatment. The dean is biased against the GR1, he is biased in favor of GR2. So what is happening is, what they mean to say is that the dean is trying to differentially treat the two groups. That's what bias is about. And this is what happens, but this is very, very important thing which happens in research. And this is what is also known as lack of the systematic error or misclassification or lack of internal. That was external validity. This is now internal validity. External validity, your study results cannot be applied to that population, but can be applied to some other population. But in internal validity, if there is a problem, then your results cannot be applied to anybody. Okay. So just an example, it is usually felt that laparoscopic repair of inguinal hernia is better than conventional open surgery, since it causes less post-operative pain and facilitates more rapid return to work. This is usually felt, especially when laparoscopy was being introduced. Now, the question was that whether laparoscopic repair is actually superior. Surgeons who do not agree with the laparoscopic repair put across objections like, Dean is a surgeon, CTV is surgeon, and when laparoscopy started coming in, there was a lot of resistance. People used to say, good old surgeons used to say, ये छेद बना के क्या देखते हैं, अच्छी तरह जब तक पेट काट के उसको नहीं खुदा तब तक पता ही नहीं चलता अंदर क्या है. So there was a lot of resistance. So they gave objections like these. The laparoscopic repair is often offered to patients who have better abdominal musculature and better general health, so naturally they'll do better. Or patients and surgeons believe that laparoscopic repair is a newer method and therefore it has to be better than the older treatment, or patients see a smaller scar and therefore they report less pain. Or maybe the surgeons after performing laparoscopic repair don't ask in detail about the pain and are less inclined to record it on the case sheet. Laparoscopy करते दर्द कहाँ होगा, पूछा नहीं दर्द के बारे में, case sheet में नहीं लिखा है. So all these things can happen. That's what the objections there. So is the laparoscopic repair, or it just appears to be better because there are systematic differences in how the patients are selected for open surgery or laparoscopic surgery, or there are systematic differences in how patients of the two groups are actually evaluated for the outcome. So these are the questions. Finally, a study which was published and which was a randomized control trial comparing laparoscopy with open surgery finally proved that no, laparoscopic repair is better after considering all these points. So what happens is, whenever we are testing hypotheses regarding associations, we naturally, as we said, we'll be comparing two groups. Either a group which has the exposure, either a group which does not. Or else in a case control study, we take a group which are having the disease, the cases, and a group which does not have the disease, the controls. And we are comparing them. Now, if at any point we start treating these patients while we are selecting them, or we are actually making the measurements on them in a differential manner. Some group is treating in a different way, some group is treated in a different way. Please mind it, it happens mostly unconsciously. It doesn't happen consciously. Consciously, you won't do it. But unconsciously, it happens. The two groups, either while selecting or while evaluating them, while making measurements, they are being treated differentially, then bias will happen. And this is what the differential treatment is. Bias, therefore, can only occur in analytical study because two groups are there and they are being treated differentially. In a descriptive study, there is only one group, so there is no bias, but there could be a basic error of measurement that can spoil the study. There are two broad categories. First, the groups that we are intending to compare, they are selected in a differential manner. That is known as sampling or selection bias. And the second point is that while recording the information or making the measurements actually on them, the two groups are being treated in a differential manner. That is known as information or measurement bias. Now, the important thing about bias is that while the chance or effects of chance, that is random error, can be evaluated later on statistically by p-value, we can get an estimate, or confounding can be controlled. I'll just cover it. Bias is something, if that creeps in, then you can't do anything. There is no estimate of bias and it will be criticized and the study will just be rejected. That is the problem with bias. Therefore, one has to be very, very careful at the point of starting the study, whether bias has creeped in or not. And you have to visualize, you have to prevent it. I'll just give you a very small example at the risk of taking a little more time. For example, there was a study which wanted to see whether mothers who have got exposure to excellent during the agricultural period are the more likely to produce of spring who are inside the environmental malabsorption. So the mothers who are delivered after 3 years of the degree, and other mothers who are giving birth to normally are everybody about the history of excellent. And certainly the research was worked out that we have 9 years 10 times. So there 10 times higher risk among mothers who get excellent exposures to deliver babies who are congenitally malformed. Now, this is a fairly very high amount of risk. There is a risk, we know, but that risk is calculated to be about 2.5, not 10. So there is something wrong. Now, what something wrong could have been there? See, what happened was that when you suffer from something, you always keep on calculating and remembering. अगर आपको कोई जिन मदर्स के बच्चे मेलफॉर्म पैदा होते हैं वो 3 साल बाद भी याद करते रहते हैं, ये तो नहीं हुआ था, वो दिन गिर गई थी, एक्सीडेंट हुआ था मेरा, children were congenitally malformed. That is what bias is, and we have to be very careful when bias comes in. Next one, confounding. Another very important thing, and this, what it means is, it's a very, very common thing in research. Compare apples with apples, not with oranges. I'll give you a very hypothetical example. Funny thing, in a study to evaluate the risk factors for IHD, this is hypothetical. Researcher took 100 cases of IHD and 100 age and sex comparable healthy controls, no IHD. They took history of various putative risk factors, many of them smoking, drinking, overweight, exercise, everything. And one of the risk factors for which they collected data was whether the subject used Indian type of lavatory, which needs squatting, or the Western type of lavatory, which requires a person to be sitting rather than squatting. The results are here. It was a case control study. So they said that 70% of the IHD cases gave a history of using the Western type of lavatory, and 30% only gave a history of using only 30% of the healthy controls gave a history of this type of history. If you calculate the odds ratio, it's called calculated the cross product ratio, A into D divided by B into C. So it comes out to 5.4. Very high risk, very high risk. Probability is also very highly significant result. So finally, they were about to give the blessed recommendation. They're sitting on the pot on a Western type of laboratory, increase the ISD risk by more than 5 times. Even cigarettes are not so harmful. The known risk of cigarettes is just about 2.8 for ISD. So everything was going against our Swachh Bharat Abhiyan. When finally we thought that something has gone wrong somewhere, something had definitely gone wrong. And what has gone wrong was that this confusion was created by a third variable, namely the affluent socioeconomic status. Because people who are from higher socioeconomic status are much more likely to use Western type of toilets, and at the same time, because of their affluent lifestyle, they are much more at risk of ISD irrespective of the type of toilet they use. And this is how confounding creeps into research. Basically, a confounding variable is one which creates confusion in your findings. It is defined as a variable which is associated with both the exposure variable and the outcome variable. And its association with the outcome is independent of its association with the exposure variable. This is how the definition goes about. But what is very important is that it is differentially distributed in the two groups which are being compared. And therefore, this differential distribution is the main science behind the control of confounding. If the two groups being compared can be made equal in respect of confounding, then the confounding effect will cease. It's very easy to control confounding, but its most important thing is you have to identify the confounding. So what you have to do is be aware of the process of confounding. Be aware of that. Whenever you do any research, there is a very huge process of confounding. And when you are developing a research question, when you are reading a lot around the subject and into the subject, try and make out a list of all the possible confounding variables that can distort your research. Talk to your seniors, talk to your mentors, peers, people who have worked in that field. Ask them what can be confounding variable. Once you have identified, then it's easy. We can take action during the planning stage. We can use restriction, randomization, or matching. It can be controlled. Or else, even if we don't do all this, we can simply collect the data on that confounder. And during the analysis, we can do a stratified analysis or a regression analysis. The effort can be controlled. But what is very important is identifying the variable and collecting the data on that. Because if you have not identified the variable, you have not collected the data on that variable, nothing can be done, and your study will be severely criticized. Even high-level projects have been dismissed, discarded, just because they had not identified the major confounding variables. Had they identified, and the problem with identification is once you have completed the research, you already submitted a report, now you can't go back to the subjects, and now you can't collect back the data on confounders. So you have to identify the variables and collect the data on that. And the last one is the proper statistical analysis is important. It enables us to describe our data, estimate the parameter of interest, estimate the effect in terms of relative risk, odds ratio. It helps us in testing the hypothesis. But what is important is that you must know the essentials of statistical probability, only the essentials. Don't go into too much of statistics, and the limitations of probability. The limitations of probability, knowing them are important. Make the best use of your statistician colleague, and making the best use of a statistician or the computer package, which are there. Number of them are available. Do remember, they will all ask you certain parameters. They will ask you the data. If your data is correct, they'll analyze nicely. Anybody can analyze it. If your data is not correct, data on confounders is missing, you have been biased, you have been, by selecting, you have been biased, then computer statistician cannot correct for it. So while I end, just 2 minutes, I would say after all this discussion, the two most important things, the two most important out of these facets of a good medical research are, firstly, the research questions should be very professionally developed. And secondly, we should understand, visualize, and prevent all possible sources of errors. You have to get an error-free result. That is the ultimate in research. And for getting a good research question, the process I've already narrated: find a general area of interest, read around the topic, then you identify a specific area, then read into the topic, formulate a tentative research question, make the tentative research question as specific as you can, evaluate it on the criteria of funds, and finally do write down your research question and something about it so that it serves as a good future reference. And the second aspect is prevent errors. These are the 5 errors. First error is the sample is not representative. It will land you in an error of external validity. What to do? We'll just go to that. The second is the results are different from reality just because of random error. This is the second type of error. This is what we call as a chance or random error or sample to sample error. Third is the basic measurement process is still wrong. The study cannot be accepted. The fourth type of error is a systematic error or bias. The two groups have not been treated in a similar manner. And the last error is a confounding error. And what we do about it is, for external validity, one thing, take representative sample by probability sampling methods. For random error, take adequately large sample as calculated by the statistical methods. And at the end of the study, calculate it and calculate the probability of random error or the p-value by statistical procedures. For errors of basic measurements, use the standard. Only thing is use standard. Definitions, techniques, instruments, reagents, observers, everything should be standardized. For confounding error, most important, identify the confounders. There is no way out if you do not identify them. Then after that, during planning stage, we can use restriction or randomization, which is used in a clinical trial, or matching. Or else in analysis, we can do standardization of rates, stratified analysis, or regression analysis. That all can be done. But the data on the confounder has to be there. And finally, for systemic error or bias, treat both the groups as far as possible similarly. किसी के साथ दाईं और बाईं आंख को अलग-अलग से नहीं देखना है. Look at them in a similar manner, treat them similarly. Thank you very much, madam.
The house is open for question and answer.
Madam, when I was there at FMC, though, there are a lot of questions used to come up in the postgraduate methodology courses. Yes.
Subject of sampling error.
I don't get it.
The study that restricting facts was the If you are reduction in the level of iron was what the study, but recently it was found to have a family two generations kept away from facts.
No, see, I'll give you some examples. It's not so easy to straight away say whether it had selection bias or it had sampling bias or it was full of confounding. Let's say ISD, for example. There was a study of a case control type. Interesting. So I'm bringing it out. In which patients of ISD who came to the CCU and those healthy controls, they were asked about the history of physical exercise, physical fitness, because they wanted to test whether physical fitness is a preventive good protective measure or not. Now, interestingly, what happened in this study, almost about 70% of the patients who came to the CCU and after they stabilized, they gave a history of good physical exercise. And 70% of the healthy controls who didn't have ISD also gave a history of good amount of physical exercise. So 70% on both sides. So this study finally said that physical exercise has nothing to do with preventing ISD, because whether you have ISD or not, 70% people give the history of exercising. Any PG can give me why it happened. It was a real study. It was published and then criticized and then it was withdrawn. Just guess what could have happened. Any postgraduate student from medicine or no, I'm just asking any PG student can give this answer. Just 1 minute. Yeah, like 70% of the ISD patients in CCU, they are saying हम लोग exercise करते थे. 70% healthy लोग जो बाहर CCU में कभी गए नहीं, वो भी कह रहे हैं exercise करते थे. Exercise तो फायदे नहीं होते. हम लोग कहते हैं उससे भी काम हो जाता है, और CCU में हो जाता है, तो कोई हो नहीं रहा. See what happened was, some of them died, 24 hours, another 10% died. So what really happened after 24 hours are at least 60%. And they were the ones who were asked. Right, now you're doing the time. So the answer was that it was information bias. It was a measurement bias. Because people who were asked where the burns, who lived to give that answer. Many people who did not exercise, who were unfit, actually died in the pre-hospital per time only or within the first 24 hours. And physical exercise, those who lived were actually exercising. So physical exercise, the final conclusion was that physical exercise, even if it does not prevent the occurrence of ISD, may still improve the survival from ISD. Okay? It was basically selection, but the way people are selected was wrong. This is how bias works. So for a bias, one has to be careful. One has to visualize from the very start as to from where these biases can come up. There was another study which finally was working on whether use of oral contraceptives is a risk factor for uterine carcinoma. So they had a very useful cohort study in one of the stronger designs. They followed up the two groups and told them whenever you have bleeding or any such problem, you come. Or after the 3 years, you get a repeat. Now, they found that those women who were using oral contraceptives, this group, the detection of uterine cancer was much more. So they came out that oral contraceptives are a risk factor for uterine cancer. But later on, it was found. See, when people now in peer reviewed journal, people start analyzing everything. So the peer reviewers said that is not the case. They said what happened was those women who are using oral contraceptives are much more likely to have